Good evening, all. Welcome all to this wonderful session by CAHO Diagnostic Division. And this is going to be on Back to Basics, session 4. And we're going to discuss about the blood and body fluid examination. And we have some eminent speakers, and I'm sure all of you all who've joined the session are going to be greatly benefited. And like the term goes, back to basics, meaning trying to look at very basic concept. And so it is very simple. And I'm sure that the faculty is going to tell you the most important thing that you have to look at. And also you can ask questions very relevant or anything that you would come into your mind. You can put in the chat box here, right? CAHO and its diagnostic division is looking at getting the diagnostic division being strengthened in all parts of the country, in every aspect and every discipline of the diagnostic divisions. So it's very good that we have this session today, and very happy to have all the participants connected today for this wonderful session. So over to you, Dr. Zubair.
Very good evening to everybody here. Actually, this is also my first time at CAHO here, so I am also equally honored and excited, as are all the participants here and the speakers. So first of all, thank you to CAHO for electing me to the governing council to represent clinical pathology. And this is the first of a kind of a subject-specific seminar. I mean, it has been there last year as well. So today, as Madam has lightly said, the theme is on body fluids. So clinical pathology and body fluids appears very simple, right? Yeah, but there are a lot of updates that keep happening, and unless we have these forums like these, we go back to basics, reiterate what we have learned, and it's very important. Otherwise, we tend to something gets routinized. We say, okay, we know it, but the learning has to be a continuous cycle, so that we reinforce whatever we have learned, and again keep our eyes and ears open while reporting. All right. So with this, I would like to introduce our first speaker. So this is it. The body fluid examination back to basics, and our first speaker for the day is Dr. Preeti, Sridharan, Chari. I have known Dr. Preeti from the past 10 years. In fact, it's interesting that we started our career together in Anand Diagnostic Laboratory, and she's been very dynamic. That's all I can say, and very down to earth as well, very bubbly all the time. She is a very unconventional person, actually. You get to know her as a person. Yeah.
Thanks a lot, Zubair, for the kind introduction and for the opportunity as well. And thank you, CAHO team, Dr. Aparna, Dr. Jayalakshmi, and I see Anila, Dr. Anila somewhere. Yeah. So hi. Yeah, thank you for this opportunity. It's a pleasure to be here. And like Zubair mentioned, it's a very basic topic, a little underrated maybe because we're usually overwhelmed with so many blood samples that most of the fluid samples get ignored. And it's rather less standardized in most of our clinical laboratory settings. But nevertheless, its importance in the diagnostics is high up there, and understanding how to go about it, following SOPs, standardizing them, and ensuring that we test appropriately with the maximum level of sensitivity that's possible to give a report is what we aim at with standardizing or process forming for body fluids. So the talk plan for today is I'll just start with a little bit of physiology and then what goes wrong in a pathological state, how do we approach the diagnosis, and the laboratory investigations, which will encompass the pre-analytics, analytics, post-analytics, and quality control, and a couple of cases followed by a summary or conclusion. So in a physiological state, basically we have the histology where there is a parietal pleura and a visceral pleura. The parietal pleura lines the thoracic cavity. It's about 20 to 25 micrometer in thickness, and it's rich in capillaries and lymphatics. The visceral pleura, on the other hand, it covers the lung. It's about 25 to 80 microns in thickness, and it provides mechanical support or protection to the lungs. The composition of normal pleural fluid, it's usually colorless. It's very low in quantity, about 4 to 8 ml. The pH is slightly alkaline, about 7.5. There are very few blood cells, the WBCs, which range from 1,000 to 5,000 cells per cubic millimeter, most of which are mesothelial cells and monocytes, followed by very few lymphocytes and neutrophils. And the chemical parameters like LDH is less than 50% of plasma. Glucose is almost the same as that of plasma. And proteins is about 1 to 2 gram per DL. And the pressure is about -5 centimeter of water. Now, this we all know. This is a basic structure of the histology that we just spoke about, where the lung is covered by the parietal and the visceral pleura. And pleural effusion is a condition where there is collection of fluid between these two layers of these two covering layers. And when the quantity exceeds, obviously, that's where the diagnosis comes into picture, and understanding the clinical context is very important. In the normal physiological state, there is an equilibrium that's maintained by a balance of both a mean rate of both production and reabsorption of fluid into the pleural cavity. And the forces that act during this equilibrium process, maintaining this equilibrium process, are the hydrostatic and oncotic forces. The hydrostatic force, which pushes the fluid away or outside, and then the oncotic force that draws the fluid towards it or inside. And most of the production of fluid happens through the capillaries, and reabsorption through the lymphatics happens at the parietal pleura. Interaction between systemic and pulmonary circulation is what happens to give rise to whatever pathophysiology exists in the pleural space. Now, collection of fluid, largely if we categorize and see how that happens in a pathological state, or when there is a change or imbalance in the equilibrium, it happens either because there is a low oncotic pressure, or because there is an elevated capillary pressure, or an increased capillary permeability, or a lymphatic obstruction. And based on these four categories, there can be an overlap sometimes. There can be more than one pathophysiology playing at the same time, or there can be a very rare condition in which none of these four categories exist. But by and large, these are the four main categories of pathophysiology. And I have mentioned here that there is the nature of fluid is transudative in nature if there is a low oncotic pressure or elevated capillary pressure, and it's exudative in nature when there is an increased capillary permeability and lymphatic obstruction. But it's not as simple as this flow chart, because arriving at this diagnosis or trying to elucidate these features is sort of a challenge. We need a lot of clinical information, the patient history, followed by laboratory diagnosis. So some of the common causes of pleural effusion, where there are examples against certain mechanisms, like increased pleural fluid formation can occur when there is an increased interstitial fluid in the lung, like in left ventricular failure, pneumonia, pulmonary embolus, increased intravascular pressure in pleura, which can be due to right or left ventricular failure, and so on and so forth. This is available everywhere. But what we need to understand is there is a definite mechanism that underlines a particular pathology or pathophysiology. So the approach to diagnosis is very simple. There has to be a thorough clinical history and a clinical workup, followed by radiological tests and laboratory tests. Of course, the talk will be focused on the laboratory test, but even while we sit in the lab and try to interpret fluid samples, it's very important to have some basic minimum background of the clinical nature of the patient, as well as some radiological tests if it's available. And the clinical history, of course, the presenting complaints are usually dry cough, dyspnea, pleuritic pain, and a detailed history, like I said, is very important, where the duration of the symptom, along with drug and medication history, the chest pain, the type of chest pain, whether it's there is cough and how long it's been there for, whether it's associated with hemoptysis, and any history of trauma, weight loss, malignancy, cardiac surgery, etc., is very, very critical. A thorough physical examination to ascertain the distribution of fluid, whether it's on both sides or it's only one side, followed by palpation and auscultation. And diagnostic thoracocentesis and pleural puncture is usually done. One of the criteria for that is if the thickness of the decubitus radiograph or the CT is more than 10 millimeter of the effusion. So therapeutic thoracocentesis in severe dyspnea to relieve symptoms is carried out. Radiological evaluation is another ball game altogether. We will not be going into that, but it holds a very important place in diagnosis and assessment of pleural effusion. Normally, it's a chest radiograph followed by thoracic ultrasound, CT, MRI, and PET scans, which are employed depending upon the type of clinical history and the nature of disease. And this is just to say that there are some specific radiological characteristics and a potential differential diagnosis or a diagnosis against its characteristic feature. I'll not go into the details of that. So coming to the lab tests, as we all are aware, we have a very basic set of lab tests for pleural fluid and some ancillary tests based on the urgency and the type of disease that we're dealing with. They're usually ordered only after the basic tests are done and when some clues towards what we're dealing with is ascertained in the clinical context, after which ancillary tests are ordered. So the routine test is usually something as simple as a gross or macroscopic examination of the fluid, followed by cell count and cell type, which is a hematology department related test, and then some chemical tests, biochemical tests like ADA, LDH, protein, glucose, and then cytology, which is also very often done because there is often a need, especially in very cellular fluids, to differentiate reactive mesothelial cells from malignant cells or tumor cells. And the ancillary tests, more often than not, that are asked for are the pH, if there is, a possibility to do the pH in the bedside or in a hospital setup, followed by culture, PCR, amylase, cholesterol, triglycerides, tumor markers, NT-proBNP, and flow cytometry, and many more. If the fluid quality is good and then the type of test allows for diagnosis, then niche tests or esoteric tests can be done. The laboratory investigation process, as we always approach, there is a pre-analytical phase, which is very, very important because that's what largely determines how our analysis and interpretation is going to be, followed by post-analytical phase and overall QC through and through the entire process. So the pre-analytics part of it, approximately 50 ml of fluid. Now I mentioned 50 ml here, but that's largely based on how much the clinician was able to take during, thoracocentesis. But generally, a 50 ml quantity is good for a laboratory to do the preliminary tests. About 10 ml of this is required for hematology and biochemistry assays, and 10 maybe for microbiology. It's usually to be collected in a sterile tube, and another 10 ml for cytology and cell block. And if pH has to be done, we have to draw a sample in a heparin-coated tube at the bedside itself for blood gas analysis and pH determination. It should ideally be, so any fluid analysis should be done within 1 or 2 hours, but maximum up to 4 hours from the time of collection if we don't want any change in the biochemical content of the fluid. The transportation of samples is 2 to 8 degrees C, and storage is also 2 to 8 degrees, but in such cases also, the sooner we test, the better it is. And as far as the analytical processes are concerned, sample processing SOPs and standard testing processes have to be determined. Quality checks have to be there throughout, especially for the analytical side of things. Technical skill and expertise for handling fluids, whether it's the technicians of the lab or the reporting doctor experience and expertise, is very, very critical. The routine test. For the routine test, like I mentioned, there is macroscopic or gross examination. One of the first things that the clinician wants to know is whether we're dealing with a transudate or an exudate, because a lot of the therapeutic intervention will be determined by the nature of the fluid based on whether it's a transudate or exudate. And to determine that, we use the popular lights criteria, which uses LDH and protein. And we'll come to that, but we do a basic biochemical assay to establish the lights criteria. Both we need the serum as well as the fluid values to arrive at the ratio. And then a cell count and cell type to assess the cellularity. How cellular is the fluid and what is the nature of these cells? Whether they are more in neutrophils, more in lymphocytes, or are we dealing with malignant cells? That's what we need to determine at the basic level. So the normal pleural fluid, like I mentioned a little earlier, this is the composition. So we need to know this because we benchmark everything against this. It is a colorless or straw-colored, thin in consistency, and the pH is slightly alkaline, with very little protein, normal glucose, LDH is 124, gram stain is negative, cell count, occasional white blood cells, and culture insensitivities will not have any growth. While we assess the macroscopic or the gross appearance of the fluid, it gives us a lot of clue. We have to capture it. If possible, a good lab practice will involve capturing the image of the fluid as it is received, so that there is no mismatch in the description versus what's been received. Usually transudate fluid are clear or straw colored. When there is pus, we suspect empyema. When it's milky, we suspect chylothorax. Bloody or red to brown fluid is seen in hemothorax, which is seen as a consequence to either malignancy or trauma or pulmonary embolism or traumatic tap. If it is blackish in color, one suspects fungal infections and malignant melanoma. If it is turbid, it could be because of pyothorax, and that can be due to an infectious cause. Turbid fluid can be chyle or pseudochylothorax and is seen in trauma, lymphomas, congenital disorders, long-standing fluid, and fibrotic pleura. And if there is feces-like odor, it can be because of some anaerobic bacterial infection. And if there is urine-like odor, it could be a urinothorax. So when there is a blood-tinged suspected hemothorax-like fluid that we receive, the bright red indicates fresh bleeding, and the brown indicates that the blood has been present for a longer period of time. A hematocrit, if possible, can be performed in such situations. It is usually more than half of the blood hematocrit. And turbidity, if the fluid is centrifuged, the supernatant is usually clear in pyothorax. So this is the core of the chemical analysis, which is differentiating the transudate and the exudate. The pathogenesis in transudate is when there is an imbalance in pressure, high hydrostatic or low oncotic pressure, whereas in an exudate, it's usually because of increased capillary permeability or a lymphatic obstruction, which I just mentioned earlier. The transudate tends to appear clearer and more pale yellow in color because it has lesser cell content and lesser protein compared to a more turbid looking or a cloudy or a bloody high protein, high cellular content exudate. And these are some of the specific differences between the two in terms of the specific gravity. One is low, exudate is higher, total protein is lower, it's higher in exudate. And the fluid to serum protein ratio is less than 0.5 in transudate, and it's more than 0.5 in exudate. And we also have the lights criteria, which distinguishes the transudate from exudate, where there is a protein ratio of the pleural to serum, which is usually less than 0.5 in transudate and more than 0.5 in exudate, and the LDH. So these are the two things that are taken into consideration for calculating or arriving at differentiating the two based on lights criteria. I'm not sure about the challenges that you guys face, but sometimes in standalone laboratories, you don't get serum sample. It's very difficult to, calculate this ratio. So we just go by basic values and somehow put them together and then give a diagnosis of a possibility of a transudate or an exudate based on the values. But if you have both, then it's great because you can directly give a more meaningful report based on the LICE criteria itself. And the common causes for transudative, the disease conditions is when there is a hypoalbuminemia like a nephrotic syndrome or cirrhosis, or in congestive heart failure and constrictive pericarditis. Whereas in exudative, it could be because of autoimmune diseases, esophageal rupture, infection, malignancy, pancreatitis, post-CABG or pulmonary embolism. This is a very interesting chart. I just copied it out of Google. It's from JP edition. And this approach is very, very sensible, very easy to follow this, and makes a lot of sense when we try to put up an algorithm in the lab, especially when it's a diagnostic thoracocentesis pleural fluid that we get. The approach here is first to understand whether it's exudate or transudate, which is based on LICE criteria. Once we've established that, we further, if it's a transudate, well and good. I don't think there is any more tests required because we know what the underlying disease is, and it has to be treated depending on that. But if it is an exudate, then we go on to see the cell count, the type, then we do special tests like culture and gram stain, EDA, interferon, and gamma, interferon, gamma, glucose, and amylase. And if amylase is elevated, we can suspect an esophageal rupture or a pancreatic pleural effusion or malignancy. And if the glucose is less or lesser than 60 milligram per DL, then we can suspect a malignancy, bacterial infection, rheumatoid arthritis, or connective tissue disorder. And maybe with help of radiological tests, we can also do a spiral CT and ascertain whether a further biopsy or thoracoscopic or open pleural biopsy is necessary. Now, if in case the ADA is elevated, we obviously have to think of tuberculosis, especially when it's more than 100 or 150. And if the cell count is very high and it's neutrophilic in nature, then we think of gram positive or gram negative bacterial infection, and cultures have to be done accordingly. So some of the common examples of exudates and transudates, like we just mentioned earlier, it's enumerated here. The biochemical tests, the pH, like I said, if it has to be done, the sample has to be collected anaerobically in a heparinized syringe and analyzed within 1 hour using a blood gas analyzer. The glucose is usually normally, low glucose is normally associated with a low pH and high LDH. ADA, it is an enzyme that catalyzes the conversions of adenosine to inosine. When it is more than 45 unit per liter, it suggests tuberculosis or rheumatoid pleurisy or empyema. But when it's more than 100, it's almost highly suggestive or confirmation of tuberculosis. Triglycerides in chylothorax triglycerides values are more than 110 milligram per DL. Pleural fluid triglycerides less than 50 milligrams can exclude chylothorax. In cases of pleural fluid TG of 50 to 110, lipoprotein analysis may be required for the demonstration of chylomicrons. C-reactive protein may be done rarely when there is a neutrophilic exudate with C-reactive protein level of more than 45 milligram per liter will most likely be parapneumonic in nature. And if the pleural fluid CRP is more than 100 milligram per DL, it will be complicated parapneumonic effusion. Procalcitonin is another marker that can be used to diagnose the systemic bacterial infection. Amylase, like we saw earlier, it may be elevated. And upper limits of normal serum, that is 100 to 130 unit per liter, and a pleural fluid to serum ratio of more than 1 are seen in pancreatic diseases, esophageal rupture or malignancy. Tumor markers may also be used, like CEA, CA125, CA15.3, or other tumor markers, although the sensitivity is slightly lower when we do it on the fluid specimens. NT-proBNP may be done in certain situations. It is a useful biomarker with high diagnostic accuracy for distinguishing pleural fluid of cardiac origin with high sensitivity and specificity. And like we discussed, the LDH and cholesterol also are a part of, mostly a part of the basic test that we do. Coming to the hematological tests, the exudative pleural effusions with predominantly neutrophils, more than 50%, mean there is an acute process going on, such as parapneumonic effusion and pulmonary embolus or viral infection, gastrointestinal diseases, asbestos pleural effusion, malignant pleural effusion, or acute TB pleurisy. Exudative pleural effusions with predominantly mononuclear cells indicate chronic process like malignant disease, pulmonary embolization, pleural effusions, and following coronary arterial bypass surgery and TB. So you can see that there is actually an overlap between the two. Between certain conditions like in tuberculosis and certain other infections also, where you can actually have more mononuclear cells as well. And eosinophilic pleural effusions are seen in more than 10%. When it's more than 10%, are mostly because of air mixed or blood in the pleural space, or it could be because of malignancy, parapneumonic conditions or transudates, and whole or drug reaction or parasitic infestation or Churg-Strauss syndrome. Special hematology tests like flow cytometric analysis, if there is good expertise, technical as well as reporting pathologists, then that can also be employed, especially if there is a high suspicion of hematopoietic malignancies. The workflow in hematology is usually, if possible, to do a centrifugation, especially when the fluid is straw colored or it is very thin in consistency. A centrifugation would give a better yield. A cytospin also, if possible. And conventional counting is on a Neubauer chamber, but automated cell particle analyzer may also be used if you have a provision for it. A body fluid mode on a 5-part analyzer, and microscopic review of stain slide, preferably using a GIMSA stain or a PAP and HNE if you want to appreciate the morphology better. And here is where I'd like to talk a little bit about automation and body fluid analysis, where especially morphology and cell counting is used. It's better to have as much automation, at least if the lab allows for a budget and for its technical capabilities, because it obviously improves the sensitivity of testing. It increases the repeatability or precision of testing. There is better accuracy. The errors are minimized. The TAT is much faster. It's less labor intensive, and interface of value saves us a lot of time and error of data entry. So cell counting and microscopic examination, of course, the best is to go for a body fluid mode on a 5-part analyzer if you have it, where normally it gives us the WBC count if there are any RBCs, and reactive mesothelial cells and monocytes all get clubbed together. Atypical cells are flagged usually, and yeah, so this is when, depending on the type of analyzer we have a cell counting feature for it. And like I said, it can be done on the Neubauer chamber itself. If we have, especially some of the technicians who are really good at counting on the Neubauer chamber, can also do it that way. Cytology is specifically for morphological analysis, especially when there is a need to either exclude the presence or absence of tumor cells, basically to ascertain whether there are tumor cells or not. And the best is done when there is a cytospin fluid or a cell block, because it improves the sensitivity of the test. Skilled reporting pathologist is definitely required for this. and it has to be assessed in the clinical context and other findings. And immunohistochemistry on cell block can be done to differentiate reactive mesothelial cells from mesothelium 1 adenocarcinoma. This is just one small example. This shows us reactive mesothelial cells, which is the first one, and where you see that they're all uniform cells and vacuolated cytoplasm, whereas there is mesothelioma in the center and an adenocarcinoma towards the right with all high NC ratios and hyperchromatic nucleus and some mucin in the cytoplasm. Microbiological tests can be done if there is a suspected aerobic or anaerobic bacterial infection. TB cultures can be done, Gram stain and AFB stains also can be done depending on what's being suspected. And these are just some examples. I'm not sure how visible this is or how legible it is, but these are just examples of what we just already went through, the various disease conditions and implications of each of these routine as well as esoteric or ancillary tests that are done in the laboratory. Post-analytical, the challenges are the same across, which is basically to have a standardized reporting protocol. Preferably, a lab should have a consolidated way of reporting, but it's very challenging because the TAT may be very different for different departments. Like at least if the cell count, cell type, and the biochemical parameters can be reported together, then even for the lab, it is useful to know whether you have categorized the fluid as a transudate or an exudate, at least to that extent. But if more can be done, then it's great. And keeping in mind that a good description of the macroscopic appearance or the gross appearance of the fluid has to be present on the report. Interpretative remarks wherever necessary, especially if you want to suggest further tests and what kind of tests you want to suggest, can be added in the report. And transcriptional errors, like I said, are usually minimized if interface is possible, especially for the cell counts. And sample storage, retention, and discard protocols have to be defined by the lab as per the guidelines that they follow. But retention criteria and storage is very important because if additional tests are asked for, not cultures obviously because you need sterile samples, but if you need to use the sample again for additional tests, then it has to be stored in proper temperatures. Overall, patient TAT is really important. I mentioned patient TAT here because for the clinician, from the time they have sent it, they're already waiting for the report to land on their table. Quality control is, like I mentioned, it can be employed in every stage from the time the sample is collected to the time the report is dispatched. But at best, what we should follow is have a protocol for quality control in the processing area. And regular have the values of proteins and sugars and the biochemical parameters. But what we can see is on the cell counter, we do find that it is moderately cellular, moderately to, less moderately severe, cellular. And the mononuclear cells are about 90% and the polymorphs are the remaining. And when we use a digital platform for morphological analysis, even in the hematology, I'm not talking about cytology here. I'm talking about our regular smears that we see in our hematology lab. If some extra level of automation or digitization is involved, then the yield is usually, better after cytospinning and scanning it. Then the machine does most of the extraction of the cells and it displays all the cells to you for you to view it. And this was moderately cellular smear with predominantly lymphocytes, with few neutrophils and few reactive mesothelial cells. And it was in the hematology department itself, we could kind of figure out that it was negative for atypical cells. It was just a simple case. Another case of a 70-year-old male, pleural fluid. Again, it's very, very sparsely cellular. Again, all sorts of tests were asked, and including TB PCR. 10 ml of straw-colored fluid was received, and it was a sparsely cellular, but almost all the cells were lymphocytes, and it was basically a transudative fluid. And this is another case where it's a pleural fluid, 65-year-old male, and it's highly cellular, as we can see here. The mononuclear cells, which is lymphocytes, is 99% of all the cells, and it's pale yellow with in color, and about 4 ml was received. So here we see that it's sheets of mononuclear cells, and it was just a lymphocyte effusion. The ADA was 85 and TB PCR was positive. So this was a case of tuberculous pleurisy. And this is the last case, 70-year-old male, a known cancer patient who presented with shortness of breath, fever, and lethargy. Pleural fluid aspiration was done and cytospin preparation was done. And we saw these really large cells with hyperchromatic nucleus. They all look lymphoid or in nature. It was after multiple other ancillary tests as well, and immunohistochemistry and perhaps flow cytometry, a B-cell lymphoma was diagnosed. So in summary, laboratory tests must be ordered and analyzed in the clinical context, always correlate with radiological findings, whatever, even if it is an X-ray. Lab diagnosis is mainly to differentiate transudates and exudates using Light's criteria. Lab tests are categorized into basic biochemical and hematological tests and ancillary tests. Use lab automation wherever possible, and ensure quality control protocols are defined at every step, including ILCs. And sample integrity and pre-analytical processes is very critical to analysis. Skilled lab personnel for reporting is very crucial. Thank you.
Thank you, Dr. Preeti. That was a very elaborative and concise presentation. I think you have covered every aspect of the topic really well. And we can see there are a lot of, a few questions as well.
Okay.
So, yeah, we can just take the questions. So there is one in the Q&A here. Are EDTA or heparin coated tubes only to be used for biochemical analysis? That's the question.
Yeah, preferably EDTA, and second choice would be heparin. Yes. For biochemical analysis?
Yes, for biochemical analysis.
Yeah, it's best.
Yeah, there's one more in the chat box. That is it so that the pleural fluid devoid or with very less mesothelial cells and lymphocyte-rich fluid favor TB, while pleural fluids very rich in mesothelial cells rule out TB?
No, I'm not sure if, I mean, you can do an observation and study about 100 such cases, but I don't think there is any such specific correlation. For TB, ADA is the first thing that you have to rely upon. The second would be a specific test for TB itself. On the hematology analyzer or cell count and cell type, there tends to be more lymphocytes. Mononuclear cells are predominant. But the amount of cellularity, I mean, I've seen several cases where the cellularity has been very low, but it is still tested for positive with a high ADA for tuberculosis.
Dr. Rashi Mehta writes, but mostly consultants send in simple sterile container. No bifurcation of sample is done. I think this is in response to the first one.
But mostly, yeah, so that's fine. I mean, I think if we're testing within 1 or 2 hours, it really doesn't matter. But is that how it is? I mean, if you're within a hospital setup and they draw freshly, I mean, they give you a freshly drawn sample, then you can, use it for culture if needed, because it's from a sterile tube. And later you can put it in EDTA if needed, if you're going to test it at a later stage. That's okay.
Yeah, Dr. Rupesh writes here, if the volume of fluid is less than 15 ml, inaccessible through radiology, how to do therapeutic testing or any collection procedures?
Yeah, I mean, you should not take risk. If the volume is insufficient, or if there is a short sample for any of the assays, because most of these machines for biochemical tests are automated, you must have a minimum quantity. And of course, I think 10 ml and 5 ml are not a problem, but if it's less than that, sometimes they just send very little. This is not the forum for that, but CSF fluids are a big challenge out there, especially when they send very, very little quantity of sample and they want a lot of tests to be done on it. Or sometimes they'll send you 2 liters of sample and they'll ask you only 1 test to be done. So we keep facing situations, very diverse situations, but I think you should never risk reporting on short samples if it's extremely low in quantity for biochemical and biochemical assays. Yes. What you could do is just prepare a smear and see whatever morphological analysis you can do on that and report it. That's it.
Dr. Preeti, I have a question. I know you have a very good experience in flow cytometry. So my question is, in a resource poor setting, which is better for confirmation of malignancy, immunocytochemistry or flow cytometry for pleural fluid?
I think for pleural fluid, if a cell block is made, immunohistochemistry is better. Yeah, because even if you have flow cytometry, I think handling pleural fluids and treatment of pleural fluids and the running it on flow cytometry is not all that easy. It's definitely not very easy. It can be done. I mean, especially if a hematological malignancy with a very high level of cellularity, it can be done. But I think immunohistochemistry on cell block gives extremely good results.
I think there's one more question. Can the pleural fluid analysis be done? The most common practice, I think, is to send the sample in a sterile container. I don't think nobody now follows it to sending it with EDTA and heparin and all. Most common method is to send it in a sterile container, because there are panel of tests, and most common along with them is microbiological tests. So those always take a priority. Once the microbiological tests are done, only then the routine analysis can be done from the same center. Unless there is a huge volume of fluid which they can give, then there is not a problem. But the most common sample, I think, is in a sterile container. So all biochemical tests are can be done.
Thank you. Another question is, for flow cytometry to be collected in which tube?
EDTA.
Pardon?
EDTA.
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 Yeah. Can pleural fluid analysis for biochemical parameters be done if sample is sent in sterile containers?
It can definitely be done. See, one of the reasons, if it's a fresh fluid, it can always be done within 4 hours. But if you're going to store it even for 24 hours, degeneration is going to happen. Maybe the biochemical stability may not be, it may not change too much, but hematological testing will definitely get affected if you're going to test it beyond 8 to 10 hours in a sterile container without putting any anticoagulant, because blood cells may be there, RBCs may be there. So you must have an anticoagulant.
Right. When the Zn positivity in pleural fluid is very low, can molecular tests be helpful?
Yeah, I'm sure, because the resolution of the test itself is more amplified compared to a regular smear or a Zn test. Usually, if it's if it's exudative in nature and if it's got a lot of, if it is thick or it's like pus, then I think the yield is better of whatever bacteria, and I'm sorry, the Zn positivity may be better. But if you're looking at low transitive in nature and we're still suspecting tuberculosis, then I think molecular tests are better. Someone's asked about when to prefer centrifugation and when not to. So again, a very turbid sample, you don't need to centrifuge, because you can just assume that all of what needs to be there is present throughout the fluid. But a very thin fluid, which is almost a colorless fluid, where you feel that the cellularity or the protein or its composition has very less number of cells, then I think it's always better to centrifuge.
Coming here, I mean, I feel when you are having a thick smear, for a smear analysis, you would like to centrifuge and take the, sediment. But many a times for biochemical analysis, there's no option. You need to centrifuge the sample, take the supernatant over there and do the analysis. The more clearer, better. In spite of that, if it is thick, sometimes you do a dilution with the saline or something so that you're able to analyze, and then only you do the processing of the sample.
Thank you again for joining.
Thank you, Zubair. Thank you, everybody. Thanks.
Thank you. So it's my privilege to welcome Dr. Renuka here. So ma'am holds MBBS degree from BJ Medical College, Pune, and has completed her post-graduation and DCP and DNB from St. John's Medical College, Bangalore. She continued to work as a faculty in St. John's Medical College for 3 years and then established Chari Diagnostic Laboratory in 2004 and got NABL accreditation for it in 2010. She herself is an NABL assessor. She has 22 years of experience in the field of pathology and laboratory medicine and has been instrumental in bringing up Chari Laboratory to the current status of a recognized referral medical diagnostic laboratory. She has been a guest speaker for various CMA and conferences and has also independently hosted workshops and CMAs. She is a chairperson of IARET Trust and founder and trustee of Chari Foundations Bangalore and principal of NS Paramedical College. She has been a co-investigator and laboratory head for more than 10 clinical trials. She has published and was editor for the Laboratory Investigation Handbook meant for primary care physicians in 2006 and co-editor of Arthritis News, a newsletter by IARET being circulated free of cost to all primary care doctors. She has various publications in peer-reviewed national, international, and scientific journals to her credit. So ma'am has a lot of recognition and rewards. To name a few, in September 99, she received the award for academic excellence in the post-graduation exam. And Feb 1998 was presented the best paper in the postgraduate KCIPM. And November 2000, ma'am received Dr. Jagdeshwari Mishra Award for the best oral presentation for ovarian tumors. And in November 2004, Best Paper Award at IRA-CAHO 2004 for the role of anti-CCP in the diagnosis of suspected early rheumatoid arthritis. With all this rich background, especially in the field of immunology, we are all thrilled and just eagerly waiting to listen from the pioneer herself, Dr. Renuka. Over to you.
Thank you. That was such a nice introduction, Dr. Zubair. First and foremost, I would like to thank Dr. Zubair, CAHO, for having accepted me. I mean, for giving me this opportunity to speak on this forum. And it is really nice that they are covering up some simple topics which are very important in our regular day-to-day working. Basically, because it is these techniques which are much ignored in most of our laboratories, I would say many a times. We end up working into all the higher end investigations, and some of the basics are sometimes forgotten and left to the junior most clinical technician in our lab. So I'm glad that they have taken up this. And today I will be speaking on synovial fluid analysis. Synovial fluid analysis is also a very different aspect of fluid analysis. And we do see quite a few cases over here because we are associated with the Rheumatology Center. And I'll just talk about the basic of synovial fluid analysis. And yes, it goes without saying that all the quality control procedures, which has already been mentioned by and highlighted by Dr. Preeti, has to be followed at all times. And I take it for granted that these things have to be followed. And I'll just focus more on the procedure and techniques and then talk about a few cases. What do you mean actually by synovial fluid? The name itself comes because it's a very viscous mucinous substance which resembles an egg white. And that is the reason why this fluid has been called as a synovial fluid. This is a particular joint space, which I'm saying, and here there is a bone, which is covered by the cartilage and then covered by the synovial membrane. And then there's a cavity here, which is the synovial cavity, which contains the synovial fluid. So this fluid actually provides lubrication to the joint. It reduces friction and it acts as a shock absorber for these joints. And that is what gives us a protection. So as aging happens, as any problem or any stress is there or injury is there, then this hemostasis can get affected. Synovial fluid is supposed to be a non-Newtonian fluid. What does that mean? It's basically that whenever there is an increase in the stress on the fluid, the viscosity of the fluid changes. So if you look at water, you hold a water in a bottle, you move it 100 times, it will not change the viscosity. But what happens in a fluid like a synovial fluid, as the pressure on it increases, or as stress increases, then the changes happen in the synovial lining and the viscosity goes on increasing. The synovial lining is basically, here this is a synovial lining. This is basically a histology picture and of the synovium to show that it is lined by the synovial sides, which does not have a basement membrane. And it is more like it has quite a bit of a phagocytic activity as well as synthesis it does. And here is the capillaries. It has a connective tissue. And what is synovial fluid is basically, it is a plasma dialysate or ultrafiltrate of the plasma. So the fluid, the plasma which traverses through the connective tissue and into the synovial, along with the constituents which are secreted by the joint tissue, is what is there in the synovial fluid. So it contains a very special substance, which is the hyaluronic acid, which gives it the viscosity, the lubricin, collagenase, proteinase. And as I said, because it is a plasma, dialysate or ultrafiltrate, it has all the other contents of a plasma, such as glucose, uric acid, and proteins. And it is important that we measure them. So the glucose and the uric acid levels in a synovial fluid are usually on par or just a slightly lower than that it is in the plasma. However, the protein levels are generally much lesser, basically because it does not transfer the big proteins such as the fibrinogen or alpha-2 macroglobulin or beta-2 macroglobulin and so on. So whenever there is a joint swelling, a patient has an arthritis, he has swelling, tenderness, so then synovial aspirate is done, and it is useful for diagnosis of various arthritic conditions. And it could be because of inflammatory arthritis, such as gout, rheumatoid arthritis, pseudo-gout. Sometimes even you might have arthritis in conditions such as lupus, Sjogren's, and other connective tissue disorders. It could be because of infections. Septic arthritis could be there either because of bacterial infections, or it could be because of mycobacterial infections. Let me be telling, and then it could be just a simple non-inflammatory effusion, could be either because of osteoarthritis or degenerative changes, or it could be a hemorrhagic arthritis or hemorrhagic infusion because of either trauma or PVNS or malignancy. So the diagnosis of various type of arthritis is done basically with multiple others. See, most of them are systemic conditions, and there will be other indications, and diagnosis is done on serological findings. But many a times when there is a joint fluid which is accumulated, and a synovial fluid definitely helps. And it is very important, we have to have a proper clinical picture, understand what are the joints which are involved, how many joints are involved when we are reporting the synovial fluid. So the synovial fluid usually either taken from the knee joint or the elbow joint, wherever it is usually the most common sites where they are collected from. Synovial fluid is just about less than 3.5 ml to 4 ml is what you usually find in a normal content. If there is an effusion, then naturally, of course, the volume might be increased. It is ideally collected in a plain sterile container for culture. You should ideally have 3 tubes. Then you may have either a heparin or EDTA tube per cell count, and again a plain sterile tube for chemical and cytological analysis. But what I would say is many a times we do get, as it was already discussed in the previous session also, we do only get a single container with for chemical and cytological, but you have a good communication with your clinician, then at least you can ask for your counts whether you can send another sample in a EDTA or heparin, but depends on the volume of the content that we are getting. So we should remember that you may not get a very high volume at all times. The sample should be sent to the lab at the earliest for an analysis. The earlier we examine the smear fluid, the better. But if we are not able to transport it, then immediately keep it refrigerated and transfer the sample at 2 to 8 degrees Celsius. Once the aspiration is done, what are the things that we observe in the synovial fluid? We look at the gross examination with the negative. We look at the physical properties. Biochemical examination is done, microscopic, of course, and culture. So culture may not always be helpful, but sometimes it is very helpful, but it may not have a very high sensitivity. The gram stain might help in such situation. Now let us just go to the gross examination. This is basically a graphic representation because we don't have all 5 slides samples together. So this is just a graphic representation. Normally, synovial fluid will have a straw color or it is colorless. This is what it would be, either like water or somewhere in between it would be. Then if it is non-inflammatory, usually it will be a yellow color or it would still be a straw color. And as the inflammation increases, it becomes more opaque and yellow and inflammatory. So, and sometimes if there is a crystalline disc arthropathy, you could even have white. And if there is blood, it could be called as a hemorrhagic. So the color will vary depending on whether it is what is the kind of a condition. I would just like to mention that if it is fresh hemorrhage, then it will be bright red like this. If it's old hemorrhage, then it will be either brownish or somewhere it is golden brown color. Basically because that means probably that the patient is having a bleeding tendency, a PVNS or trauma, which is earlier induced. Whereas if it's a traumatic tap, then where it is more of an iatrogenic condition, then it might usually be a fresh blood. Normally, it is transparent, which I showed you in the previous slide. And as the inflammation increases, the transparency goes on reducing and it becomes more opaque. So both in normal and non-inflammatory, it is transparent. In inflammation, it can be translucent. If there is severe inflammation, it may go on to form opaque white color or purulent. And of course, as I said, if there is bloody, it could be because of either a traumatic shock or it is a trauma to the joint, and any bleeding disorders, particularly something like hemarthrosis, wherein a patient has a pactate or any other coagulation defect or PVNS. This is another picture sometimes you might find. So this is something looking like, it has an ochronotic fluid kind of a thing, but basically it's not ochronosis. You may have this kind of a brown particles whenever there is a because these kind of fluids, which we'll see probably in the future more because of the different joint replacements or the metallic procedures which are there, the prosthetics, that can sometimes give you this color. I had brought in this picture basically for that. Or also if it is something like flakes of, what you called as rice flakes, it can sometimes be seen in rheumatoid arthritis. Besides, see, what as I said is synovial fluid is a little different. Besides, because of the presence of the hyaluronic acid, it is quite viscous. And so besides that, we have to look both for viscosity, mucin clot, when we are doing the physical examination of the synovial fluid. So what you do is a very simple test, which is a string test. So you drop the synovial fluid from the syringe and then you put it into when you're putting it into a tube, when you're holding it, we should look at the length of the string, how it is. Usually it is always more than 4 centimeters. But suppose if when you're holding it and it is dropping out in drops and it is not forming a string, that means the viscosity has come down. And that is because there is a degeneration of the hyaluron that has happened, which will then cause the reduction in the viscosity, which could happen either due to inflammation, trauma, or crystals. Now, this is a mucin clot test, which we do in synovial fluid. So what you do over here is when you take a synovial fluid and add it into a tube which contains acetic acid in a ratio of 1:4. You take 2% acetic acid. To that, you drop a little bit of synovial fluid which you have collected. It will usually form a firm clot with a clear fluid in the background. And then you shake, it will still stick like that only. Okay, it will be very sticky and form a firm mass in a clear background. But same thing, if suppose you add the synovial fluid into the clear, we have added quite a bit of synovial fluid over here. We have taken more volume of acetic acid because I wanted to demonstrate this. And if you shake the synovial fluid, the tube which is containing the acetic acid, this you see a firm clot here, but here it becomes friable and breaks. And this whole thing becomes little whitish, which indicates that there is a dilution of the mucin, which is usually seen in inflammation. Normally, a good normal synovial fluid will form a firm mucin clot. So that was for the physical examination and the macroscopic examination. And then, of course, a chemical examination is done. Glucose, as I've said, it is usually, being an ultrafiltrate of plasma, it is just about 10 milligram lesser than the serum values. And but if a marked reduction in glucose is there, then you should start thinking in terms of an infection or a purulent or a pyogenic or a septic kind of a inflammation which is there, or unless the fluid has been left aside for too long and it has got contaminated. We have to keep in mind the other problems which are there, and we have to interpret it based on that. The protein usually is 1/3, so it will be normally 1 to 3 grams per deciliter, which increases in inflammatory arthritis, namely ankylosing spondylitis associated with Crohn's, UC, gout, Reiter's. In all of them, sometimes the protein level will be high. Uric acid is generally on par with the serum level, so 6 to 8 milligrams, which will increase in gout usually. And when you see that the uric acid in the serum is, when the synovial fluid is high, we should also look for the presence of any crystals of it. And lactic acid, not much asked, but very rarely it is asked. We hardly get the query for that. And in synovial fluids, we do not include it in our analysis thing. But if they ask for, we do it. And it's very rare. Normally, it is less than 25 milligram per deciliter. It increases to more than sometimes 1,000 milligram in septic arthritis. Only other condition in infective arthritis where it doesn't usually increase is in gonococcal if there is inflammation, and it is there. Cell count, see, basically, yes, definitely, as Preeti said, the more automation we do, the better. But many a times when it comes to a synovial fluid, it is very difficult to run them in automated cell counters and it is difficult due to the viscosity of the fluid which is there. So manually is what we do most commonly, and in our lab we follow a manual procedure for synovial fluid, wherein you take a clean centrifuge tube to which you add 380 microliters of 50 dilution. So you take 380 microliters of the fluid and 20 microliters of the sample, mix it for 10 minutes, and then mount it on the new gas chamber. Then you do the usual count, which is the number of cells counted. So you use a new gas chamber. Of course, I'm sure everybody here is well aware about it, that you take a new gas chamber, and on that you take you do the calculation by doing the number of cells which you see on the chamber with the dilution factor which you have used, the number of spares divided by the number of spares you have counted and the volume of each can. Usually we use the last 4 chambers which you use for WBC count. So finally it is 50N. But mind you, if the count is very high, when it goes to 30,000, 50,000, then in that case, the dilution factor should be changed and it should be increased. And if the count is so very low, less than 5 cells, 10 cells and all that, at that time, like in CSF, you can use all the 9 chambers of the thing and do a direct analysis or do a one dilution and do it. So when it comes to the counts of synovial fluid, normally synovial fluids will have very low count. If you just take a normal, it will be it says less than 200, but most of the time it will be around 40, 50 cells. But otherwise, in a normal sample, why will they do a synovial fluid in the first place? So when you say normal or in a non-inflammatory arthritis, usually the cell count is low, and in normal it is less than 200. Polymorphs are also low. You will have predominantly lymphocytes which are there. The mononuclear cells will be the ones which will be present. Whereas in non-inflammatory arthritis, the count is still a little higher than in normal, So you can get up to 2000 cells, but the polymorphonuclear cells will still be low. So it will be still predominantly lymphocytes. I didn't mention that in synovial fluid, we get basically the polymorphs, lymphocytes, few synovial sites is what you usually see. Then in inflammatory, you of course see there is a high count. This should be 75,000. I'm sorry, it's showing 2,000. And polymorphs will be very high, up to 50% or more. And when it comes to purulence, you might get counts which are more than 1 lakh. Yeah, here it is a stain smear. So you do usually not just a wet mount, you have to do a stain smear. You can do a Leishman stain. And we in our lab, we also do compulsorily for all synovial fluids, we also do an HND stain. So we say a stain smear also in our report. And we do a differential count on the count. So you might find polymorphs, lymphocytes, synoviocytes, RBCs will be present. Very rarely, if there is malignancy, you might find, but hardly, we have hardly ever seen any malignancies in synovial. So coming to then when you have said that the inflammation could be an inflammatory arthritis, then as I said, there could be always a possibility that the patient has some crystal-induced arthropathy. And that being the case, so we have to do a polarizing microscopy for most of the all the synovial inflammatory arthritis. We do a polarizing microscopy for them, all of them, because which is useful for identification of crystals. Here you look for the birefringence. So what do you do by birefringence? You look for the ability of a substance to refract the light and split it to the incident light, which is fast, and a slow light, which is ray, which is a perpendicular length. Here you use one analyzer, which is there in the, which is usually fixed onto the, this can be done, accommodated into a regular microscope. You don't require a separate microscope for it. So you, in a regular microscope, you can fix an analyzer over here, which can be fixed and kept. It will not interfere into your regular work. And whenever you get a sample, then you keep a polarizer over here and you see it and you rotate it and see it. So it just needs a little bit of a habit of doing it regularly, and you will get it very easily. And then you allow the light in one direction to pass, and at 90 degrees, it blocks to give it a dark background. So sample with crystals between them will reflect light, allowing it to pass through the analyzer and appear shiny in the background, which is dark over here thanks to polarizer here. One thing is that you will have a negative birefringence for most of the crystals which are seen in synovial fluid, urate crystals, CPPD crystals. So if you see for whether there is a negative birefringence or a positive birefringence. So what are the types of crystals which you see in synovial fluid? Mainly, most commonly you see the uric acid whenever there is a gout, which will have a negative birefringence. And you can sometimes you find CPPD crystals, which are little rhombic in structure, and we have a positive birefringence. Cholesterol crystals are extracellular. You have seen them in other fluids, of course, where you find notched rhombic plates. This can sometimes be seen in arthritis, usually rheumatoid. And corticosteroids, because of the intra-articular injections which are given, which are of variable size shape, and which may be positive or negative birefringence. So we should not get be careful not to report these corticosteroid crystals as other calcium appetite crystals or hydroxyapatite crystals over here. And you can also get very rarely oxalate crystals, most likely usually in the patients with renal dialysis. And sometimes you might get hydroxyapatite crystals, which do not have any birefringence at all. And you actually sometimes see cartilage fibrils in the patients with osteoarthritis. So just to come back to this, normally synovial fluid will be low volume, about less than 3.5 ml, 4 ml, transparent, colorless, straw colored. The mucin clot will be normal. Normal means it is firm, and viscosity will be normal, is usually thin and stringy, which is if you take pour it through a syringe, you will find it coming as a small string, and cell count is low, less than 200 cells. RBCs are very low, no crystals and no bacteria. So this is what it is. So let us just look at a few cases of synovial fluid. And I'm sure anybody will be able to come if you have in mind that these are the criteria, and we look into all of them. So in all our cases, we make it a point to see for all of these things, volume. So here, this is a case 1, which is a 4 ml sample, and where we received a synovial fluid, which was pale yellow, translucent. Viscosity was normal, mucin clot is firm, proteins was about 2.5 milligram per deciliter, that is normal, sugar is 60. Microscopy WBC count is 350 cells, predominantly lymphocytes, no crystals. HND stain again shows predominantly lymphocytes with few polymorphs and occasional synovial cells. So this looks very clearly like a, because the cell count is between 200 to 2000, the rest of the parameters of inflammation are not there much. It is looking like a non-inflammatory or synovial effusion. This was a picture which we saw. Occasional polymorphs, quite a few lymphocytes, and I think this picture of course shows more polymorphs, but otherwise it does. So now this is one more case wherein we took a 6 ml synovial fluid which we has received, yellow in color. It was opaque, so viscosity is decreased and mucin clot is friable. So that means possibly here itself there is an indication. Proteins are also high and sugar is on the lower side. So this is looking like there is some inflammation. WBC count, then when the differential count was done and a wet mount was seen. So WBC count shows 23,500 cells per cubic millimeter. Lymphocytes are 32%, polymorphs are 68%, so polymorphs are predominant. In addition to that, we see rhagocytes. What are these rhagocytes? These are basically polymorphs only, but in the WBC count, what will happen is you might find some of them which are having debris, or because of the formation of the immune complexes which get deposited on the neutrophil. So you see these rhagocytes in the smear, no crystals, and HND shows, of course, polymorphs with a few lymphocytes and occasional synoviocytes. So this is an inflammatory arthritis. In addition to that, you are seeing here rhagocytes. So this was a case of, we have put it, of course, as inflammatory arthritis, but we do get samples, and this patient was a case of rheumatoid arthritis and whose CRP level was also high and anti-CCP was positive. Actually, we don't, most of the time, synovial fluids are not very commonly done in our center, but we do get samples from times wherein the, where it is difficult, or when it so happens that we get it from many of the other orthopedicians that we get synovial fluids more commonly. But sometimes when it is doubtful, that's when we get those cases. And this is another case wherein the synovial fluid was 15 ml, opaque. I would have loved to have this as a, a small teaser and ask the PGs in between. It would have been really nice to have this as a discussion. So with opaque, decreased viscosity, friable mucin clot, and protein is of course little mildly raised. Sugar is come very down. It's come down to 20. Microscopy WBC count is very high, 92,800, predominantly polymorphs, 90%, no crystals. Show so many polymorphs with few lymphocytes, occasional synovial, but see the count, nearly 1 lakh. So we have put it as acute inflammatory arthritis, suggestive of septic. Then we have asked for a microbiological correlation. And it so happened that this sample had also come for microbiology, and it was showing it did grow some colonies. And sometimes we should, here also again, we should see whether it is involvement of a single joint or a multiple joint, because the septic arthritis are generally involving a single joint. And many times even tuberculosis for that matter usually involves a single joint, not always. The history, whether it's involving the joints of the small hands, the small joints of the hands, or is it the larger joints, all that also makes a difference when we are getting the sample, and we usually ask for that. This was another case, a 30-year-old male with a history of pain involving the ankle, knee, hand, and elbows, along with backache. See here it is involving multiple joints, and aspirate done from a nodular swelling and the interphalangeal joint. Cheesy material was what we got. There was no enough fluid for analysis. So what we just got was 1 or 2 slides on which some cheesy material was put, and a little bit material on that syringe which was stuck to the slide. and it had come for microscopy. So definitely we could not do an entire fluid analysis, but when it was done for staining, because it was already collected on a slide, this is what we saw. There were sheets of crystals over here, all needle shaped, like, broomstick or a haystack, what you would call, is what we saw. And under polarizer, this is how it looked. So this is a uric acid crystals, needle shaped crystals with negative birefringence. And this was the only thing which was there. We could not do any other analysis on this case. And of course, but with the presence of crystals, it was very clear, and it had an interphalangeal joint also that was done as per it. And it is what was, we called it as a gout. The other crystals which can sometimes see are the CPPD crystals, and these are usually having a positive birefringence, so they appear very colorful in the when we do the polarizer. But the only difference over here from those is they will not be so needle shaped, and they will usually have parallel, lines at the edges, and you can differentiate by the thickness and the size, and they are much smaller than those of the uric acid crystals. This was a case which we had got recently when we are talking of gout. We had got one more case like this. So which was a 56-year-old patient, and with a uric acid level of only 2.5 serum uric acid. CRP was very high, 103. Rheumatoid factor was low, less than 20. ESR was high. And this was patient when we got the fluid. So this was a 15 ml fluid with yellow color, turbid, low viscosity, and mucin clot was friable, protein was high, sugar was normal, I would say, and WBC count was high, but not very high. And then here we had this sample wherein when we looked at it under the wet mount, so you have this few synovicites, macrophages. Then within the macrophage also we found that there was something like a small needle-shaped structure which was there. And then we put it under the microscope. And again, we saw a needle-shaped structure. And we got a doubt that this looks like a case of gout. And of course, we did not get a history for this patient. So then when we call, then they tell, yes, it is a patient known of gout. I don't know why was that done. So we gave it as inflammatory arthritis suggestive of gout, but patient had been referred and had already been given colchicine, hence the low uric acid levels. So just based on the serum uric acid level, sometimes we get misguided because the patient was already on therapy. But that's why whenever you get an inflammatory arthritis, just don't ignore it and see that whenever you have a doubt, please look it under the polarizing microscope and look carefully for the crystals in a synovial fluid. So that is what I would like to say, that a very good clinical interpretation is required, whether it be a hemorrhagic fluid where you need to know whether it's traumatic, or whether it is because of a hem bleeding disorder, or is it because involving a single joint. Look for the crystals, simple techniques, but then you have to follow them properly. It helps a lot in the coming to a conclusion for a diagnosis. I have seen that many of the labs do not do the usual mucin test or the viscosity, and they just generally report the same as color, clarity, and okay, I'm seeing few lymphocytes, inflammation is seen, and that is what is very commonly reported with synovial fluids. But it is important that we follow all of this. And of course, it goes without saying, quality procedures have to be followed. Whenever you're doing an assay, your pipette has to be calibrated, your Newbart should have good readings, there should be no pre-analytical, post-analytical. That will be, I'll not get into the entire quality thing here. But what I would like to say is it is very important you do a fluid analysis, and you also see that you do the complete workup of it and take a history. That will definitely help us in giving us a proper diagnosis. Thank you so much.
Thank you, ma'am. It was really enlightening. Many aspects of it we refreshed, I think, all of us. There's some questions here in the Q&A, ma'am. First question from Dr. Manoj. What is the diluting fluid used for counting cells in synovial fluid? WBC diluting. We still use the WBC, but sometimes some people do say do not recommend it, but then we still use the WBC diluting fluid. Because, sometimes if it's a little bit, many a times there is a little trauma and those RBCs interfere, but otherwise you can even do a direct, if the smear is clear, you can just mount it directly and see it under the microscope without really doing a fluid. Do not using a diluting fluid also. Okay, the doctor is using here a normal saline as diluting fluid.
Yeah, normal saline can be used. Normal saline can be used. They actually sometimes recommend you can very well use a normal saline. But if you feel that it's hemorrhagic and it's interfering, because see, another thing what I wanted to say, I removed that slide, that if it is a hemorrhagic aspirate sometimes, then you have to sometimes use a WBC diluting fluid. You can use a saline also. Very well, you can use a saline. Even for doing the biochemical analysis, many a times we dilute it in saline because it's a viscous solution. We use it in saline and then 1 in 10 and then do the analysis for that.
There's a second question from the same doctor. In case of automated cell counter by cell counters, do you use hyaluronidase to make the thick synovial fluid thin and aspirable?
I haven't done that, so I have no experience about that. Maybe someone else has used it, they can give a feedback on that actually.
Ma'am, I have a question. How often is synovial biopsy being done?
Synovial biopsy, we do it regularly. We keep getting synovial biopsy. Even yesterday, we have reported it quite commonly. See, now what has happened is earlier we used to get a lot of fluids, even synovial fluid and biopsies. But now with better techniques of diagnosing autoimmune disorders and other arthritis conditions, wherein serological markers are available and autoimmune diagnostics are available, the need for doing an invasive procedure becomes lesser and lesser. So only sometimes it is really being done. Earlier we used to get quite a few, but now we get much lesser. But we do get synovial biopsies on a regular basis. And sometimes we do see other conditions. So we have reported cases like chondrocalcinosis and PVNS, rheumatoid arthritis, all of those conditions regularly we sometimes, even I think I have a case today also.
Can I ask a question? How do you look for crystals if you don't have a bright field microscope, especially for people in lesser resources?
That's what I'm saying, ma'am. See, basically, if we are using a regular microscope and you get this polarizer some attachment, where you get an analyzer and a this thing, you just put it, you get a separate attachment. You ask your microscope guy, it doesn't cost much. It's quite cost effective. You put that and put it into your regular microscope. Whenever a sample comes, you just do the attachment to a regular microscope and see it. You do not need a separate bright field or a dark field microscopy for that.
Because many centers do not have any bright.
We don't require a bright field microscopy. What you just get, if you just ask your vendor, he will give you the microscope guy. Usko bolenge to he will give you that analyzer or polarizer milta hai. You just put that attachment. So analyzer can be fixed permanently onto that which is there, and polarizer is a separate attachment. We just keep it in a drawer over there, fix it to that whenever you require it, and just see it under the microscope. Regular microscope, it can be attached to any microscope for that matter.
And regarding the crystals,
even a monocular for that matter.
How often are you able to crystals? Do they ask regularly?
Crystals, we get a query. Sometimes they don't even ask for entire synovial. They'll say synovial TCDC and crystals. Like that, we get queries sometimes. Or sometimes they give us synovial fluid analysis. Then we, of course, do the entire volume, whatever mucin, clot, viscosity, everything over there. Because it helps us in giving a proper report, actually. Whether I give it as inflammatory or non-inflammatory. So, based on the count, the other parameters, it becomes easy for us to report a synovial fluid analysis. Otherwise, all fluids, you will say inflammatory or non-inflammatory, negative for malignancy. So you can't use the same thing, in this, because they are not suspecting a malignancy here. What they are actually looking is how you can help me, whether it is inflammatory, non-inflammatory, crystal induced. What is it that I'm looking at?
Sure. Thank you.
Sometimes thick samples which can't be pipetted are requested for LDH or other biochemical parameters. How to process them?
It is a little thick, then you can. If it's too thick, you cannot. But if it is mildly thick, then you can, do a dilution, but then you can tell the clinician and you can write it in your report that the sample was processed on dilution of so-and-so, and then given the report with calculations. So they are in the loop and you at least get some approximate idea. If it is too thick, it's very difficult, but most of the time it is viscous, no doubt, but not so much that you can't do anything. When you can't do it, you just tell them we can't do it. These parameters itself will help you. Even if you don't do protein, the mucin clot test, viscosity, as well as the counts will help you in doing the report.
It was an excellent session, I would say. That's the first thing, and very, very simplified so that everybody can understand with pictures so clear. you're crystal clear, no? Your crystals are very clear as well.
Yeah.
So, and
Yeah,
very
no,
simple and
yes.
easy for anybody to understand, anybody who's in the lab,
I'm
you
sure.
know, and not just the postgraduates, even technical staff
Technicians,
would be, yeah,
exactly.
it's very, very simple and easy, and really enjoyed listening to both of you today. Very nice.
Thank you so much.